And we all know that aortic stenosis is one of the degenerative valve disease, and it is the most common reason for aortic valve surgery or Tavi in Western countries. Even in our country, it is a rheumatic heart disease, still the most common reason for aortic stenosis and bicuspid aortic valves we see more often than Western countries. And symptomatic severe AS has dismal prognosis, and early intervention is strongly recommended in these patients. Since the first in human procedure in 2002, almost 20 years, Tavi has become a well-established therapy for severe AS. So it's a progressive disease. The normal wall leaflets are very thin. As the disease progresses, there is a progressive increase in fibrosis followed by calcium and the commissural fusion, leading to mild, moderate and severe aortic stenosis with reduced valve orifice and increased gradients across the wall. There are various grading of class aortic stenosis. It's normal less than aortic jet velocity less than 2, mild is less than 3, moderate 3 to 4, and more than 4 is severe. And based on that, the mean gradient less than 25, or some guidelines say less than 20, 20 to 40 is moderate, and more than 40 is severe. And ACC-AHA classifies very severe aortic stenosis. That is, if the valve velocity is more than 5 or mean gradient is more than 60 millimeters of mercury, that is classified as severe aortic stenosis. But the onset of symptoms marks very reduced survival in these patients, because there is a long latent period between disease onset and severity of the symptoms. And once the patient develops symptoms like angina, syncope and heart failure, the average time for death will be, if the patient had angina, it's averagely 5 years. Patient had syncope, it's 3 years, and if the patient had heart failure and breathlessness, it's only 2 years survival. And 50% of the untreated patients with aortic stenosis will die within 2 years of experiencing symptoms. So Tavi or surgical aortic valve replacement will definitely improve the survival, almost 40% improved in survival if the patient underwent timely intervention. Until they develop severe LV dysfunction or severe frailty, these patients will have good prognosis. So there are the ACC-AHA proposes different classification, that is A, B, C, D. Class A is patient is at risk of developing aortic stenosis in future, and B is progressive. That means already patient had mild to moderate aortic or other valvular lesion. This nomenclature is common for all valvular lesions. And stage C is asymptomatic and severe, and stage D is symptomatic and severe valvular stenosis. So in case of aortic stenosis, at-risk patients will be patients who have bicuspid aortic valve or patient who had aortic sclerosis on routine echocardiography. And as the patient become progressive AS, they become mild to moderate, increase in valvular gradients with increase in calcification and fibrosis of the bicuspid or tricuspid valve, and rheumatic valve with commissural fusion. These comes in progressive AS, and respectively the valve hemodynamics and hemodynamic consequences on the LV, like early increase in LV diastolic pressures with normal LV ejection fraction in progressive stage. But in asymptomatic stage, patient may be having LV dysfunction, but patient will not have a symptom on routine daily activities. But if they are subjected to exercise stress testing or some of the other markers like BNP, they will be having elevated brain natriuretic peptide, which are indirect indicators that LV is under stress. And these are subclassified into D1, D2 based on the LV ejection fraction, and high flow, high gradient AS, and D2 is low flow, low gradient AS. And these are all patients has to be thoroughly evaluated. The first and foremost test will be transthoracic echocardiography, which shows the valve morphology, amount of calcification, gradients, and along with that, and its effect on the systemic and pulmonary circulation and LV dysfunction. And apart from history and physical examination, ECG also carries important prognostic and information in these patients, and the therapeutic implications too. And apart from these, what are other additional investigations? The chest X-ray may show about pulmonary circulation, whether the patient is in heart failure or intrinsic lung disease, which decides the choice of therapy and calcification of the aorta and pericardium. And transesophageal echocardiography may not be much useful in aortic stenosis, because transthoracic gives most of the information, but some of the patients it may be definitely helpful. And cardiac MR, if the patient LV dysfunction, LV mass, valve severity and aortic disease. And PET CT, especially if the patient is suspected infection but you don't know the source of infection, it can help in localizing infective endocarditis. And stress testing, if the patient is asymptomatic or if the patient had low flow, low gradient days, this gives information whether to intervene or not. And cardiac catheterization, it's not routinely recommended, but it helps in equivocal cases. There is a discordance between the symptoms and the echocardiography findings. The other important markers that comes into the guidelines is biomarkers, especially brain NAT, BNP. If the BNP is more than 3 times the normal, even if the patient is asymptomatic, it's a class 2A recommendation for aortic valve surgery, whether it may be SAVR or TAVR, based on the age and other criteria, and strain imaging and cardiac MR. So other important tests for pre-procedure planning is CT, coronary angiogram, or regular angiogram, along with CT for aortic valve and peripheral, the femoral artery size, and is there any tortuosity and calcification at the puncture site and aortic calcification. This gives important information whether the patient is suitable for femoral approach or any other approach we need to follow, or we should send the patient for surgery. If the patient had severe aortoiliac disease, he may not be suitable for transfemoral TAVI. We may need to choose other modality of treatment in these patients. So this is a summary of these things. Patient, after diagnosing aortic stenosis, patient has to be thoroughly evaluated, and based on the symptoms, ECG, echo, and cardiac CT. And next comes the heart team discussion, including cardiac surgeons, cardiologists, interventional cardiologists, patient and their family members. So we need to decide which therapy is suitable for the patient. So if the patient had high flow, high gradient days, that is high gradient days, we need to assess the flow status. If the patient had high flow status, and it needs to be reassessed because it may be falsely high gradient, we need to reassess after stabilization. And if the patient had normal flow with high gradient days, we need to give we need to consider it as severe AS. And if the patient had low flow, low gradient aortic stenosis, we need to, with the valve area is less than 1, we need to assess if there is any increase in flow reserve with the low flow dobutamine stress echo. And if there is increase in flow reserve, if the patient aortic valve area is less than 1, that is an indication for this patient is diagnosed with severe AS. Then choice of therapy will depend on the other risk factors. So if the patient is diagnosed with severe aortic stenosis, then we need to choose the therapy, that is TAVR or SAVR. So it depends on the various factors like patient-related factors, procedure-related factors, and processes-related factors. With the patient age, depends on the comorbidities, life expectancy, and patient preference, and procedural risk, that anticipated complications, and peri-procedural risk, anatomy of the valve, operator and institutional experience. And other important thing is processes factors, that is whether it is mechanical valve or tissue valve. In tissue valve, whether it is surgical valve or bioprosthetic valve, depends on the heart team discussion. So initially it was only surgical AVR since 1960, almost 40-50 years, only surgical AVR was the standard therapy. And in surgical AVR, whether it is mechanical valve or bioprosthetic valve, depends on the patient age and other indications or contraindications for the oral anticoagulation. Since 2002, the first TAVR was implanted, and based on that, it got approved in 2011 for patients who are at high risk for surgery. And later on, it intermediate and patient got approval in almost 2015, and 2019, even low risk patients got approval for TAVI in selected patients, not in all. So these are the landmark trials that has brought TAVR therapy into the limelight. That is partner 1B trial, initially for high risk patients, and partner 1A trial, TAVR plus surgical AVR in high risk, and the partner 3 and adverse low risk trial, that is in low risk patients. So then we need to have a risk stratification. There are various online tools, that is STS, predictor of mortality scoring, and Euroscore 2, and these cannot be applied in total to every patient. We need to have a heart team discussion along with the patient, and we need to consider other factors that are not in the risk scoring. That is, if the patient is frail, these are not considered in the scoring systems, and as well as anatomical factors that have serious consequences on surgical AVR, that is like porcelain aorta, previous chest radiation, and patient had mitral valve disease. So these are some of the comorbidities that favors the therapy prior mediastinal irradiation or ascending aortic calcification. These favors TAVR, and if the patient had severe iliac occlusive disease, for transfemoral, the other modality, other access sites may be used, but these are not in guidelines as of now. It may be come in the upcoming guidelines. And if the patient had severe MR/TR that requiring surgery, or if the patient had valve morphology unsuitable for TAVI, then the SAVR is preferable. And some of the patients, even SAVR, surgical or TAVR may not be suitable if the patient life expectancy is less than 1 year, if the patient had severe COPD requiring home oxygen therapy, severe irreversible pulmonary hypertension, severe Harvey dysfunction, hepatic dysfunction, and severe frailty. These patients are not suitable for any of these procedures. The conservative management will be helpful in these patients. So these are the various characteristics. If the patient is young, surgical AVR, higher age, there is TAVR will be preferable, and previous cardiac surgery TAVR will be having edge over surgical AVR. Active or suspected endocarditis, again surgical AVR, and thrombus in aorta. These factors favor the surgical AVR. And if the patient had significant multivessel CAD requiring surgical revascularization, this SAVR is the only option. And sometimes if the lesions are very focal, you can do PCA and TAVR. And severe primary mitral valve disease, tricuspid valve disease, and septal hypertrophy requiring myomectomy, these are the patients who are slightly favorable towards surgical AVR. So we have diagnosed the severe aortic stenosis. What are the guideline recommendations? If the patient had severe aortic stenosis, that is valve velocity more than 4 meters per second and gradient is more than 40 millimeters of mercury, intervention is required, whether it is SAVR or TAVR, based on the other risk factors, other comorbidities we need to decide. And intervention is recommended even in symptomatic patients with severe low flow, low gradient aortic stenosis with ejection fraction less than 50%, but the gradient is less than 40%, and aortic valve area is less than 1. And even if the patient had low flow, low gradient AS with normal ejection fraction, and if the patient is symptomatic, it's a class 2A recommendation. And even if the patient with symptomatic aortic stenosis with low flow, low gradient, with reduced ejection fraction, and if other factors are not deciding, then if the coronary CT calciums of the aortic wall, if it is more than 3000 in men as per ESC, and if it is more than 2000 in men as per ACC, it's an indication for AVR, whether it may be surgical or TAVR. It's a class 2A recommendation. If the patient had severe comorbidities and if their life expectancy is less than 1 year, it is a class 3 recommendation not to do any procedure in this. Suppose if the patient is asymptomatic, if the patient had LV dysfunction, that is ejection fraction less than 50%, again it's a class 1 recommendation. Even in asymptomatic patients, very severe AS and with demonstrable symptoms on exercise testing, that is fall in blood pressure more than 20 millimeters on exercise testing, it's a class 2A recommendation for this patient. And exercise testing symptoms are there, again it is a patient having symptoms on exercise testing, it is a class 1 recommendation for it. And very severe AS, asymptomatic, it's a class 2A recommendation. And severe valve calcification and rapid progression of the symptoms or rapid progression of the velocity, that is more than 0.3 meters per second per year, it is an again class 2A recommendation. And markedly elevated brain BNP is more than 3 times age and sex related normal range on multiple occasions and repeated measurements without any other explanation. This is again class 2A recommendation. So you have decided the patient requires some intervention, whether it is a SAVR or TAVR. We need to again assess the patient. If the patient is less than 75 years or very low risk for surgery, or in patients who are operable and is not suitable for transfemoral TAVI, again SAVR is class 1 recommendation. And patients who are more than 75 years and who are at high risk for surgical AVR or unsuitable for surgery, there is a class 1 recommendation for TAVR. Other patients, TAVI or SAVR depends on the clinical, anatomical and procedural characteristics. Non-transfemoral, if the patient is not suitable for transfemoral, then other access for TAVI considered, there is a class 2B recommendation in ESC. And balloon aortic valvulotomy in patients who are waiting for SAVR or patients who are hemodynamically unstable for other non-cardiac surgery, it is a class 2B recommendation for balloon valvotomy. And if the patient requiring surgery for other indications like aortic ascending aorta disease or other valve lesion, that is a class 1 recommendation for surgery. If the patient is considering for CABG or surgical intervention on ascending aorta, it is again SAVR is preferred with class 2A recommendation. So this is a summary of the ESC guidelines. The patient is symptomatic or asymptomatic. The symptomatic valve severe AS, it's a class 1 recommendation. If the age is less than 75, SAVR is preferred. More than 75, TAVR. And what is the role of TAVI in aortic regurgitation? This is not in the guidelines, but in selected patients, it may be considered if the patient anatomy is suitable for TAVI. Similarly, ACCHA, patient's age is less than 65 years of age, surgical AVR is preferred because of long-term durability of the TAVR valves is not yet established, only 8 years, but surgical valves, that is more than 10 years. If the patient age is less than 65 and life expectancy more than 20, SAVR is recommended. And patient's age between 65 to 80 years and no anatomic contraindication to transfemoral TAVI, either SAVR or TAVI may be recommended based on the heart team discussion. And if the patient's age is more than 80 years of age, and even in younger patients, if their life expectancy is less than 10 years and no anatomic contraindication to transfemoral TAVI, the TAVR is preferred in these patients. That is class 1A recommendation. And if the patient is less than 80 years and LVF less than 50, the decision between TAVR and SAVR should be considered based on heart team discussion. For asymptomatic patients, severe AS, abnormal exercise test, very severe AS, rapid progression of symptoms, SAVR is recommended in younger patients and TAVR in older patients. For patients, the vascular anatomy, other factors not suitable for TAVR, this SAVR is preferred. And for symptomatic patients whose post-predicted TAVI or SAVR survival is less than 12 months or minimal improvement in quality is expected after surgery or TAVR, palliative care is recommended. This is a class 1 recommendation again. So if the patient, general agreement patient age is 80 years or as per ESC, if it is more than 75 years, TAVR is recommended. Between 65 and 80 years, TAVR or SAVR based on other risk factors. TAVR is associated with shorter hospital stay, more rapid return to normal activities, low risk for transient or permanent AF, low risk for major bleed, but SAVR is associated with less risk of paravalvular leak and less need for valve reintervention and permanent pacemaker. But with improvement in valve technology, the paravalvular leak is less with the more advanced valves. So, as there is a general agreement, both ESC and Canadian Cardiovascular Society recommends TAVR in more than 75 years or old, but ACCHA more than 80 years, TAVR is recommended if the life expectancy is less than 10 years. So there is general agreement between all the guidelines. There are various 5 to 7 society guidelines are there, Canadian and STS guidelines as per, apart from ACCHA and ESC. So these are areas of agreement, definition of AS, role of heart team, and role of severe AS in more elderly. These recommends TAVI, but there are some areas of disagreement between age and consideration of BNP and other surveillance in mild moderate AS. There is some difference in opinion, but still there is some gaps in evidence. That is the comparison between minimally invasive surgical AVR and TAVI in bicuspid valve, TAVI in the assessment of stratification and cerebral protection during TAVI. The TAVR has become preferred treatment over SAVR in elderly patients. However, there are several limitations for TAVR, including stroke, conduction system disorder, durability of the prosthetic valve, and bicuspid anatomy. And TAVR and SAVR had a complementary role rather than a competitive role in patient management. Thank you all.